Okay, let's talk about alcohol misuse. It's one of those things we see all the time in general practice, right? But it can be really challenging to manage. It's often hidden in plain sight, tangled up with a ton of other physical and mental health problems. So in this explainer, we're going to cut through all that noise. We'll give you a super clear, practical clinical pathway from the moment you screen a patient all the way through to their long-term management. So just how big of a deal is this? Well, have a look at these numbers. They're pretty stark. We're talking about nearly a third of men and about 1 in 6 women in the UK drinking above the recommended limits. Think about that for a second. This isn't some rare condition. This is a huge public health issue, and these are the people sitting in our waiting rooms every single day.
And that really gets to the heart of it, doesn't it? These patients are in your surgery day in and day out. They might be coming in for their blood pressure or maybe for anxiety, and you have that little suspicion. But the big question is, how do we go from just suspecting there's an issue to actually, identifying it, properly assessing it, and then genuinely helping them? That's the roadmap we're going to lay out.
So here's our plan. We'll kick off with the scale of the problem. Then we'll dive into screening and identifying risk. After that, it's all about brief interventions using a great model called FRAMES. We'll also tackle the really tough stuff, managing dependence and withdrawal. And finally, we'll wrap up with long-term support and relapse prevention. Let's get into it.
All right, first section, the scale of the problem. So let's really dig into why this is such a critical topic for us in primary care, especially right now. You'll see how the pressure on the whole healthcare system really starts right here, in our practices.
Get this, a 17% jump in hospital admissions where alcohol was the main culprit, and that's over a recent 10-year span. Now, that's not just a number on a slide. That's a rising tide of liver disease, serious injuries, mental health crises, you name it. It just goes to show why what we do in primary care, spotting this early and stepping in, isn't just good practice. It's absolutely essential to try and turn this tide.
Okay, section 2, screening and identifying risk. So the problem's huge. We get it. But how on earth do we find these patients in the middle of a crazy busy clinic? Well, the answer is structured, simple screening. Let's look at the tools.
Here's a super high-yield comparison of the go-to tools. Let's be real. In a 10-minute consultation, you're probably not going to do a full audit questionnaire, and that's where FAST and Audit C are your best friends. Think of them as your quick triage. If you get a FAST score of 3 or more, or an Audit C of 5 or more, ding, 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 that's your signal. That's the patient who needs a bit more of your time, and that's when you pull out the gold standard, the full 10-question audit.
And what's so great about the full audit is that the score isn't just a number. It's a clinical roadmap. It literally tells you what to do next. It neatly sorts patients into risk levels and gives you a clear action plan. A low score? Great. Give them some positive feedback. A score of 8 to 15? That's your cue for a brief intervention. But once you hit 20 or more, that's a huge red flag. We're thinking possible dependence, and that means it's time for an urgent referral to specialist services.
Now this brings us to a really critical point, and definitely a classic for exams. What's the difference between risky drinking and actual dependence? Well, the ICD-10 gives us the official criteria. You're looking for 3 or more of these key features. Things like a powerful urge to drink, not being able to control it, getting withdrawal symptoms, or, letting everything else in their life slide because of drinking. If you can tick 3 of those boxes, you've got a diagnosis of dependence.
Okay, moving on to section 3, brief interventions. So for that big group of patients in the middle, the ones with hazardous or harmful drinking with that audit score between 8 and 19, a brief intervention can be surprisingly powerful. So let's look at a fantastic tool to help us structure that 5 or 10-minute chat to make a real difference. It's called the FRAMES model.
This model is just brilliant because it gives you a structure that's all about empathy, not lecturing. So, F is for feedback. Just give them the facts about their risk, non-judgmentally. R is for responsibility. You make it crystal clear the choice to change is theirs and theirs alone. A is for advice. Simple, clear advice on how to cut back. M is for menu. Give them options, not orders, like what about trying a couple of drink-free days a week? E is for empathy. This is key, just showing you understand. And finally, S is for self-efficacy. This is about boosting their confidence, helping them believe that they can actually do it.
Right, on to section 4. Now we're getting into the really high-risk end of the spectrum, managing dependence and withdrawal. This is for your patients with those high audit scores, or the ones who clearly meet the criteria for dependence. Here, our whole focus shifts to safety, red flags, and managing what can be a really dangerous withdrawal.
Okay, AKT exam tip, and a massive one for real-life practice, the DVLA. If you make a diagnosis of alcohol dependence,
You have a medico-legal duty to tell your patient they must inform the DVLA and stop driving. The minimum period is 1 year of abstinence or controlled drinking. This is non-negotiable, and you absolutely must document that you've had this conversation.
Right, before we even start talking about detox meds, we have to talk about thiamine. Think before benzos, be thinking thiamine. Why? Because chronic alcohol use just sucks the thiamine out of the body, and a severe deficiency can lead to Wernicke's encephalopathy, a true neurological emergency. So if your patient is malnourished, has dodgy liver function, or is about to start a detox, you've got to get them on prophylactic thiamine. It's that important.
This timeline is so important to have in your head. The withdrawal kicks off pretty quickly. Within about 6 to 12 hours, you'll see anxiety, the shakes, a racing heart. But the real danger zone, the part we have to be ready for, is the peak risk of seizures around the 36-hour mark, and then the peak risk of delirium tremens, or DTs, between 48 and 72 hours. That's a full-blown medical emergency with confusion and hallucinations. This is why a sudden stop can be so dangerous.
So who absolutely needs to be in a hospital for their detox? This is your red flag checklist. Has the patient ever had a withdrawal seizure or DTs before? If yes, they need to be admitted. Period. Are they already showing signs that their autonomic nervous system is going haywire? Sweating buckets, heart racing, shaking uncontrollably. They need admission. A community detox is simply not safe for anyone with these red flags.
Here we go. Another classic exam question. Chlordiazepoxide versus lorazepam. Which one do you use? Well, your standard first-line choice is chlordiazepoxide. It's long-acting, it's reliable, but, and this is the key bit, its metabolism gets hammered by a damaged liver. So if you have a patient with cirrhosis, it can build up to toxic levels. That's when you switch to lorazepam. Why? Because it's metabolized through a different pathway that's much kinder on a struggling liver. So remember, bad liver, lorazepam.
All right, final section. We've got the patient through the detox, which is a massive achievement, but the journey is far from over. The next mountain to climb is preventing relapse. So let's talk about long-term support and the specialist medications that can be real game changers.
Check this out. The number 11. What's that? It's the number needed to treat for acamprosate to stop someone from relapsing. And honestly, an NNT of 11 is pretty impressive in medicine. It means for every 11 people you treat with it, you stop one extra person from going back to drinking. This is solid proof that these medications aren't just wishful thinking, they really work.
So here are the main players. And a key point, these are pretty much always started by specialist services, not in general practice. You've got acamprosate and naltrexone, which basically work on the brain to turn down the volume on cravings. Then you've got disulfiram, which is a totally different beast. It's a deterrent. If you drink while taking it, you get incredibly sick. It creates this powerful negative association. It's obviously only for really motivated patients. And the most important thing to remember, none of these are magic pills. They are always used alongside intensive psychological support.
Okay, let's wrap this up. What are the absolute key takeaways for your next day in the clinic? 1. Screen opportunistically with FAST or Audit C. 2. Use the full audit score as your roadmap for what to do next. 3. Get comfortable with the FRAMES model for those brief interventions. 4. Know those withdrawal red flags and that timeline like the back of your hand. 5. Don't forget the DVLA rules for dependent patients. And 6. Know who to call. Have your local referral pathways sorted.
So, that's the explainer. But before you go, I want to leave you with this question. Just think about your patient list for tomorrow. Think about that person with the high blood pressure you just can't get under control, or the patient with persistent low mood or insomnia. Who on that list could benefit from a quick, non-judgmental alcohol screen at their next appointment? Because that's where this all starts. That's where you can really begin to make a difference.